Hello. Hi, everyone. My name is Dr. Mackenzie Kelly. I am very, very excited and honored to be speaking with you all here tonight. I'm guessing that you all are very busy people, just like myself. So I don't take it lightly that you took time out of your evening away from your family or away from all of your other obligations to come here and learn with me. So I just wanted to say thank you first and foremost for spending some time. I hope that it is exciting. I hope that you learn a pearl to take back to your practices tomorrow. I wanted to take a couple minutes just to introduce myself. I graduated from Indiana University back in 2016, about hard to believe. It's been 10 years for me. After dental school, I did a 1 year general practice residency at Carolinas Medical Center, not because I necessarily felt like my education was not complete. I felt very confident leaving dental school, but more so because I love learning. I love networking and meeting new people, learning new technologies. And as you can see in my continuing education section, I've done a lot of continuing education since graduation. I just finished up a course a couple days ago. I'm actually in a hotel room right now. I am in Charleston, South Carolina. I just finished up with another course. So, continuing education is very, very important to me. It's very important to always continue pushing yourself to the limits in terms of technology and new treatment modalities. I think that it allows us to provide the best type of patient care. I currently practice in Denver, Colorado. I've been here since 2020 and very proud to say I am a COIS Center graduate. My knowledge and my experience is based in science-backed evidence, something that's very important to me. Very quick, I wanted to disclose that I have received an honorarium tonight from Bavardis that allows me to provide today's educational program. So thank you for the sponsorship, Bavardis. I maintain a relationship with them as well as Pearl AI, and I occasionally create content on their behalf. I also have relationships with several other dental companies that are not mentioned in this program, but it is worth noting that my recommendations and all of my opinions are based on my clinical experience, and the products that I recommend come from my personal experience and my independent research and all of the education that I read. So a lot of my feelings were developed prior to any formal relationship. So, I want to start off tonight's program with a story of a patient who I just saw very, very recently. This patient is 28 years old and she has not been to a dentist in about 2 years, mostly because she lost dental insurance when she turned 26. She got off her parents' policy, but she likes to think she's healthy. She chooses the right things to eat, she works out, she takes her health very seriously, but she hasn't been to the dentist in a couple years. And she thought she was okay because she was not in pain. Nothing hurts her. Up until this point, she has gone to the dentist every 6 months. Maybe it got a little looser when she was in college and she wasn't at her parents' house and they weren't making her appointments for her anymore. But usually she maintains good oral health, or what she thinks of as good oral health. And she comes to me for a new patient visit, and I get to know her a little bit more. I learn a little bit about her and what's important to her. I interview all of my new patients. I get to know them before we start taking x-rays. And usually my workflow is that I will sit the patient down, get to know them, review their medical history and their dental history, and then my assistant will take over. My assistant will take a digital scan, will take a full set of x-rays, and I'll go into a different treatment room and continue on about my business. Or I'll go back to my doctor's office and start looking over and spying on the x-rays. I want to know what the patient is coming in with. And as I start to look at her x-rays, my heart starts to drop because I see small areas of decay present on almost every single back tooth in her mouth. And, it's not catastrophic decay. It's not decay. She doesn't have any bombed out teeth, what we would call bombed out, but all lesions where, my heart starts to sink because I start to think about the conversation I'm going to have with this patient when I walk back into the room. And I start to formulate the conversation in my head of what am I going to do for her? Am I going to watch it and wait and hope that she comes in 6 months from now? She just took about 2 years off from going to the dentist, but she says she's going to be better. And she admits that she's not really a flosser, but she says she usually does it for a couple weeks after coming to her dental visit. She gets inspired and she leaves. She leaves with a sample and she says she's going to floss. And, I start to formulate this conversation in my head of what am I going to tell this patient? She, in her mind, thinks she's just going to get a cleaning right after this. She has no idea that anything is going on inside her mouth. And I need to formulate the way that I'm going to break this bad news to her. And before I go any further, I want to disclose that this is a fake patient. This is an image that I created on ChatGPT. And the reason I did this is because this patient might be fake, but they are very real. They're real in my practice. And I know that each one of you on this webinar here tonight probably has one or 20 or 100 patients like this in your practice where they have small areas of decay everywhere in their mouth, and they're either coming to you as a new patient and you're trying to develop trust with them right off the bat, or they're a patient of record. And over time, as these lesions have gotten bigger, either during a short period of time or very rapidly or a longer period of time, you've given them bad news as they've continued to get x-rays year after year with you that, hey, it's time for another filling. This cavity got bigger. I know we were watching it, but it got bigger and it's time to drill. And the reason I'm bringing this up is because no matter what area of the country you're located in or what area of the world you're located in, this is a very real patient and a very real experience and a situation that we encounter every single day. And if you're like me, you're sitting here on a webinar tonight, taking away time from your family because I believe in my heart that you want to do what's best for your patient. You sat down here tonight to learn a different way of doing things and maybe something that you can add into your toolbox in your practice. And so I want to talk to you tonight about a material that I've been using called Curidot that has allowed me to change the philosophy and change the approach that I was using back from dental school. The traditional approach was you monitor, you hope for compliance, and then you fill. Eventually, when it passes the DEJ and gets into the dentin, what do? Now it's time to do a restoration. But what about all of those lesions that are still within the enamel? What do we do about those? The reality is all of those early lesions often progress. And sometimes it's very rapidly, and in other patients, it's slower, but those lesions continue to get bigger over time. And I graduated 10 years ago. When I was in dental school, I always hoped that there would be a material that we could use to regenerate teeth, and I have patients joke with me all the time about, can't you just regrow my tooth? And now we can't regrow teeth quite yet. Or, I know that there's scientists out there rapidly trying to develop those technologies, but what we can do is regenerate enamel. We can actually use some technology to take these early lesions and intervene. And this is so important because the reality is a lot of patients rarely change their behavior. They're sitting in our chairs with interproximal decay or lesions on the front surfaces or occlusal surfaces, whatever surface of their tooth, and they're sitting there with incipient lesions for a reason. It was something about their diet or their genetics or the pH of their saliva or how frequently they eat or drink. Something about them makes them more susceptible to decay. And I always felt like we are missing an opportunity for intervention. And that's so important because even if you have the best dentist in the world using absolute isolation, using a rubber dam and trying our best to place the best possible restoration, even if placed in ideal circumstances, that restoration is going to need to be replaced at some point in time. All dentistry fails. And good dentistry is something that's very important to me, but it's important to realize that all of our dentistry is going to fail. And the current average for a two-surface filling, is around 11 years, depending on the study that you read, but the current average is around 11 years. So that patient that I just described to you, if we placed a lot of conservative class 2 restorations at age 28, they would need to be replaced again at age 39 and then again at age 40 and 50. And before long, those restorations that were originally conservative start to become bigger. They start to become crowns. They start to become indirect restorations. And for me, if I can reverse that stage of decay right from the get-go, or of course prevent decay from happening in the first place, that's a win-win for me. So when I heard about Curodont, I was just like, finally, we have this technology to actually reverse decay. This is awesome. And I don't know how many of you, I can't see your screens. I don't know how many people are here watching this webinar here tonight. I can't see your comments until the end. But if you're not familiar with this product, I'm going to be honest with you. When I heard about it too, I was skeptical. I had always heard that there was nothing you could do to reverse decay. Maybe you could arrest it, but once decay was there, it was there. And for me, it was, how do I slow this down? How do I slow this down and prevent myself from having to do a restoration? I want to just keep kicking the can down the road. And I heard about Curodont and I said, that's really awesome. What do I have to lose? So I want to explain a little bit about how I use it in my practice tonight. And for those who aren't familiar with the product, it is a proprietary formulation that was developed from an awesome team of scientists in Switzerland. And essentially what it does is it penetrates the enamel and it rebuilds hydroxyapatite. So it reforms the crystals of our tooth structure. It works on non-cavitated whites and white spot lesions. So that's very, very important. And in the next couple slides, I will show you examples of great case collections so that you can have success with this material. So it works different than fluoride. Think of fluoride as a surface prevention for new decay. It is forming a harder layer of enamel on the outer surface of the tooth, whereas Curodont actually penetrates to the depth of the lesion and regenerates hydroxyapatite from the inside out. So it binds to the innermost aspect of the non-cavitated lesion, and it slowly builds hydroxyapatite crystals from the inside of the lesion all the way to the outside. So this is a very, very important slide to remember and use when you're talking to your patients about this product. So currently, fluoride is only able to penetrate the very superficial layer of the enamel. So it is this diagram over here on the left-hand side of the screen. So it is really good for preventing new decay, because that is probably the number one question you're going to get asked from your patients and your hygienists. How is this different than fluoride? I already use fluoride in my practice. How do I talk to patients about this material? And the way that I explain this material is I say, hey, this is a good way to, or fluoride is a good way of preventing new decay from happening. But once the lesion starts to show up on the x-ray, we know that it is moved through the deeper layers of the enamel, and we know that fluoride is no longer effective in reversing that decay. So this is different than fluoride because it actually is attracted to the acidic nature of the or non-cavitated lesion, and it can penetrate up to 1,500 micrometers into the enamel. So all the way up to the DEJ, but not involving the DEJ. So this is something that is really, really important to differentiate, or important to note with regards to the appropriate type of lesion to use this on. So once it has involved the dentin, you missed your window of opportunity. At that point in time, it is time to do a restoration. So I get this question a lot when I am out in the community talking about Curodont, and dentists or hygienists will say, it didn't work for me. And I say, that's interesting. Can you show me the pre-op x-ray of what the lesion looked like? And they will show me something that is needing a root canal. It's important to know that this is an awesome material and this is an awesome tool in your toolbox. But once the lesion has worked its way to the dentin, this is not heroics, guys. This is something that is used for those lesions that you're kind of on the fence and you don't know what to do with. Any of those times when you previously would have said, I'm going to put a watch on this, those are the types of lesions that you want to use this for. It is not for pulp caps. It is not for root caries. It is used for smooth surface lesions. So either on the facial surface of the tooth, on the occlusal surface of the tooth, or interproximal areas. So benefits of Curodont treatment. It is totally non-invasive. If you're like me, you love innovations in dentistry. I'm imagining that's why you're on this call tonight. You want to learn something that you can bring back to your practice. I love minimally invasive dentistry. It's something that is very important to me because we don't get enamel back. Once it's gone, it's gone. It's the only material in the body that doesn't regenerate. So even things that are minimally invasive are removing tooth structure. There are not many other dental technologies or dental treatments right now on the market that are totally non-invasive. So that's a win for me. It reduces your risk of no-show. It's a same-day solution for non-cavitated lesions. I don't know about you, but I can't tell you how many times I've had patients say, yes, I'll do that. Can we do that the next time? Can we do that filling the next time I come in for my cleaning? I want to get my teeth cleaned, and then I want to schedule my filling immediately after. And then all of a sudden they lose their insurance, they move away. they get pregnant and life gets crazy. They have a new child at home. They become a caregiver for maybe a loved one. Whatever the reason is, you cannot rely that that patient is going to come back 6 months later. So I like having control of the situation. And how do I do that? I apply the product right then and there when the patient is in the chair, because that allows me to remineralize the area. And when I look at it next time, the area hopefully and most of the time is smaller. So we avoid that filling later on down the road. To me, saving chair time is one of the most important things. That is the most costly thing in a dental practice. I know that we all want to do the best thing for our patients, and we all want to be able to provide the best type of treatment and the newest technology for our patients. But at the end of the day, dentistry is a business. We cannot give away our services for free. And the most expensive thing in the office is chair time. I would much rather apply this on the tooth because it takes 2 minutes rather than continuing to wait and watch and eventually this lesion become bigger. And a filling, even if placed very, very quickly and efficiently, it still takes time because you have to numb the patient, you have to bring them back, take blood pressure, put the bib on, you get interrupted for a hygiene check. So even if you're working very efficiently, that filling might take you 20 or 30 minutes to do. And to me, it's just a no brainer because 2 minutes is much faster than even a very small filling. It decreases the chance of long-term problems and infection. This is really huge for me. You never know, as I said earlier, if your patient is going to come back 6 months later, like they're promising you that they're going to. You never know if this is going to be the very last time that you see the patient for a while. And I can't tell you how many times I was watching lesions several years ago and hoping to keep things small and prevent fillings. And then all of a sudden, the patient comes back to me 2 or 3 years later and they need 3, 4, 5 fillings. And to me, I failed the patient. That's just a failure. Maybe before, when Curodont didn't exist and there was no other option for us other than diet counseling and fluoride and prescription toothpaste, yes, that was only the only tools available to us at that point in time. But now there's really no excuse. We have this treatment available to us. There's no reason that we can't be applying it right then and there in the hygiene chair. But my number one win with regards to using this product in my chair is it increases my overall patient satisfaction. I don't care what area you are in the country. Most patients are not showing up saying, Dr. Mack, I cannot wait to get numb today. I can't wait for you to inject me. I can't wait to get drilled on. This is so exciting for me. Even if they love you and they trust you, patients do not want to be numb. I had to get fillings the other day and I dread it. Dentists, we know, are the worst patients. Why? Because we don't like it. We know what's involved. We don't want to be numb either. And so when I explain it to my patients and say, we can do this treatment and it's totally non-invasive, there's no needles, there's no injections, there's no numbing, there's no downtime, and it lowers your risk of needing a filling in the future. Do you want to try this? Almost every single time the patient says yes. Stop assuming that the patient is going to say no when you haven't even given them the opportunity to make a decision for themselves yet. So it just overall has tremendously increased my patient satisfaction and patient retention. So we talked a little bit about this, but I just want to drill it into your brains. E1 and E2 lesions. I will show you on the very next slide what that looks like, but the key here is we're avoiding DEJ involvement. It is ideal for all surfaces, interproximal spots, and facial white spot lesions. You can also use it on occlusal surfaces as well. And it is important to note that it can be used on patients of all ages, regardless of oral hygiene habits. And I want to talk about this a little bit more. So, patients of all ages, in my patient demographic, I'm seeing mostly patients anywhere from age 20 to age 50. That's just where I'm located in Denver, my patient makeup. But you can use it on patients of all ages. It is tremendous benefit for pediatric patients. I know a lot of pediatric dentists using this a lot in their practices. It is great for patients actively in orthodontic treatment or immediately after orthodontic treatment. So I know a lot of orthodontists who are also implementing this into their practices as well. And it can be used regardless of oral hygiene habits. So it has been shown to work even in dirty environments. But I will say it is a tool of your toolbox. It is important to continue to emphasize the importance of good oral hygiene habits, a good diet, a diet that is low in acidity. So please don't misunderstand me. I think that it is very important to implement this into your practice, but it is not a substitute for oral hygiene instruction or a good diet. So E1 and E2 lesions, these are the lesions over here on the left-hand side. They are, partway through the enamel or very, very closely approaching the DEJ, but not yet into the dentin. So your window of opportunity is your green box over here. Any of those lesions that in your head you were thinking, what do I do with this? An E2 lesion, if you asked some dentists, we would jump in and drill this type of lesion because it's very close. And I am aware that lesions are clinically sometimes bigger than they show up on the radiographs, but I've had very, very good success with E2 lesions, those board type lesions where we feel guilty drilling into them. That's not what we want to do, but this is the perfect opportunity to use this material. How do I catch lesions early? So in my practice, I use AI interpretation. It helps me detect these areas of demineralization early because we're looking for these really, really small lesions. Sometimes they're hard to see or very, very hard to see quickly. And AI, there are a lot of companies out there. I currently use Pearl AI, but there is Overjet and Vidya as well as a couple other companies. I just use Pearl in my practice. It integrates with your radiographs. So it allows us to catch things early, which enables proactive care. So why use AI? If you haven't used AI yet or you're thinking about it, the number one reason I use it is because it allows technology to be the bad guy. I no longer feel guilt about what I'm about to tell the patient. I throw my x-rays up on the screen, and now the technology is the bad guy. So as I said earlier, typically my workflow is I get to know my new patients in a treatment room, and I go over what we're going to be doing for the appointment. And then I hand them off to my dental assistant and I tell the patient, hey, we're going to show some x-rays. We're going to take a 3D scan, and then I'll be back to review everything with you. And every single time when I come back into the room and I have my AI turned on, the patient starts to become curious. They start to say, doctor, what are all those yellow marks on the screen? What's that pink stuff? What are those boxes? They start to ask questions. And no matter what area you're practicing in the world, I really believe you're always going to have patients who don't want x-rays. I hear that time and time again. My patients are not unlike yours. They say, Dr. Mack, I just had x-rays 3 years ago. I had all those x-rays, when in reality, you know that all those x-rays, they really just took one PA somewhere. So I say, no, we're going to take a full set of x-rays, or I try to figure out why they're turning down x-rays. But if I can get them to take x-rays and I turn on my AI, the patient gets curious. They're no longer thinking that I'm a salesman. My hygienists become more confident in our recare visits. When the AI is turned on in the hygiene room, my hygienists are trained on the verbiage to say, yes, all of those areas of yellow are early cavities or areas of concern. The doctor is going to come in to verify that with you and give you more information about that. I know some dentists don't want their hygienists diagnosing, and I know that some dentists want their hygienist to be a very integral part of the practice. And so no matter what category you fall into, it allows our hygienists to have those conversations a lot easier. And also, there's less insurance denials because it's so easy to throw this up on the screen. All of your calculus is highlighted for you. The bone levels are highlighted for you. I find that there's less insurance denials, which is a win-win because nobody likes spending their time typing out letters to insurance. So with Pearl specifically, and I can't speak to the other software companies because I haven't used them, but with Pearl, it differentiates decay within the enamel. It designates those as yellow, and then once it gets into the dentin, it shows up as pink. Within Pearl, we can also highlight areas of calculus, so it is all designated within boxes. Notable margins are highlighted in purple. Periapical radiolucencies are highlighted in blue, and it also differentiates the levels of bone loss, which is super cool because it allows you to have the conversations a little bit easier. You can say these areas of red are where we need to have a deeper cleaning because you have more bone loss here. And it is not a substitute for our diagnostic opinion. Let me be clear. I still think it's very important for us to validate that the AI is correct. And it's also very important for us to give our 2 cents as well. But I just think of it as another set of eyes that can bring my attention to something that I might have otherwise missed. So just zooming in a little bit closer, these are lesions here on the left-hand side, areas of kissing decay, kissing incipient lesions highlighted in yellow. So these are excellent spots to do Curadont on. And then you can also see that there are green boxes that are highlighting areas of calculus. So that is a very easy way to start the conversation. I'm telling you, if you turn your AI on your x-rays, you can no longer just say, yeah, I'm just going to watch that. Because put yourself in the patient's perspective. Imagine that patient who I was describing earlier on in the webinar, that 28-year-old patient who comes in with areas of incipient lesions everywhere. If I have my AI turned on my x-rays, think about it from the patient's perspective. I can no longer say, I'm just going to watch that, because in the patient's mind, they're going to start thinking, watch? Do we have to watch it? Is there something else we can do? Is there something I should be doing in my current oral hygiene regimen, my oral getting ready for bed every single night? You can no longer just sit back and continue to watch those areas. So they work really well hand in hand. So now I'm going to show you some of my patients. So these are x-rays from my patient practice, and these are with my AI turned on the right-hand side of the screen, and just with traditional viewing on the left-hand side of the screen. So this is a very real patient who came to me and she said, Dr. Mack, I'm here for a second opinion. I don't have any pain. I just went to a doctor and they told me I need 8 fillings. And I met this patient and I had my assistant take the x-rays, and then I came back into the room, and her heart, you could just see it in her face that her heart was literally sad. She was just really saddened and her whole demeanor totally changed. And she looked at me and said, wow, I really do need 8 fillings. She diagnosed herself. She saw all of those areas of pink and yellow, and she's not a dentist. She's not a healthcare worker. And she knew that those colors meant something on the screen. And I told her, you do have 8 areas of decay, but you don't necessarily need 8 fillings. We can actually use a different type of treatment to remineralize those areas because we caught them early. They are still within the enamel, and we can actually put something on the teeth. It's very fast, it's totally drill free, totally pain free. Do you want to try that? And she says, oh my gosh, yes. Why didn't the other dentist offer me that? And I'm telling you, as you start to use this product more and more, you're going to start to notice that patients want it and call your office looking for it. Patients are very well educated now, and it might not be the correct type of education that we want. A lot of that education is coming from ChatGPT, from YouTube, from WebMD, from Google, from from Facebook, from all of the other various social media outlets. But they are becoming educated and they want to know their treatment options. So it is very important that we are able to offer them different treatment options, because it is a common term now, turkey teeth. Patients don't want their teeth drilled down. They don't want nubs anymore. They know what nubs are. They don't want that. They want different options. So as our patients are starting to become better educated, whether we like it or not, we need to be able to offer them different treatment modalities. So here is that same patient and with the traditional x-rays on the top, and then AI interpretation here on the bottom. So I think it's important here to note that part of my workflow includes other types of diagnosis in addition to AI interpretation. So I use transillumination in my practice. I will use just my eye. I'm looking at things to see if they are cavitated, in addition to AI interpretation. So you might be looking, I treated areas 3 distal, 4 distal, 5 distal, 29 distal. And you might be thinking, Dr. Mack, number 3 distal over here is into the dentin. Why did you treat that? Well, I looked at that tooth in different viewing angles. So this one angle that I'm showing here, it wasn't all the way through the dentin. So that's why it's important to have a person, still a dentist, still using their opinion and diagnosing the cavities, rather than just relying solely on the AI interpretation. But you can see that after 1 year of treatment, the AI is no longer picking up any of those lesions anymore, other than 29 distal. So you can see that almost all of them have gotten smaller or totally disappeared. Here is another one of my patients, 1 year after Curodont. So I treated number 30 mesial and number 31 mesial. And you can see that after 1 year, that The lesions are not even being picked up anymore on the x-rays on the bottom. They go from being maybe 60 to 70% of the way through the enamel to no longer being visible on the x-rays. Here is another one of my patients that I treated with Curodont. I treated back-to-back kissing lesions, number 28 and 29. And you can see that after 1 year, we had excellent remineralization of those kissing cavities. So you can see that without the AI turned on, they have gotten a lot smaller. And with the AI turned on, they are no longer visible. So I don't want to go through too many before and afters and bore you with my clinical photos here, but I just want to highlight that I have used this material now for about almost 2 years, or going over 2 years, and I have had such good success. And this is just a classic before and after that I typically see with my patients. I treated number 13 mesial, number 18 mesial, and 19 distal, as well as number 20 mesial. So you can see that the lesion on number 13 mesial has gotten smaller, and you can see that the lesion on number 18 is almost totally non-existent, and 19 distal has gotten smaller in size, and number 20 distal is almost totally non-existent. In case you are using a couple or a different type of X-ray technology, I think that this is Vidya. I'm not sure, but I think that this is Vidya, and this X-ray is courtesy of Dr. Rebecca Pounds. So thank you for providing me with the X-ray slide to show, but this is just showing another AI technology showing the before and after Curodont treatment. Same with this X-ray as well. Here is another X-ray showing before and after kissing lesions on number 18 and 19. This is courtesy of Dr. Alicia Gray. Thank you for allowing me to borrow your slide. And this is showing typical before and after results with Curodont treatment. White spot lesions. So this is a great way to remineralize white spot lesions while the patient is actively in orthodontic treatment or after orthodontic treatment. So I want to highlight that the type of visual changes you will see after orthodontic or with this type of lesion is somewhat unpredictable. I get that question a lot. Are these results typical? And I will admittedly say that I've had some good lesions and some ones that you don't get this extensive of a before and after result. And really quickly, just to highlight maybe the difference between this versus icon treatment. Icon treatment is a different mechanism of action. So when you have patients that have fluorosis or have enamel white spots that are due to the enamel being formed incorrectly, those are good indications for icon treatment. I use icon treatment a lot in my practice. I think that it is a great treatment option for patients, but it is different. It works for areas where the enamel is white because it is formed incorrectly. It is developmental. Whereas Curodont is more used for enamel demineralization. So think about those classic areas of demineralization when you take off the brackets and you see the outline of where the bracket used to be. Those are the spots that you want to be looking for Curodont treatment. So patients from this week and how I would use Curodont treatment. So some of these patients I would absolutely use Curodont, and some of them I would not. This X-ray up here in the top middle, obviously tooth number 30 needs restorative treatment. That is not a case selection that you would want to be using for Curodont treatment. And then you're going to have to make the choice with regards to that tooth specifically. You can see that area of demineralization on the distal aspect of the tooth. So in that situation, when I am removing the area of decay, if my decay gets underneath and starts to undermine the distal ridge, then I would extend my restoration to include the distal surface. So in that situation, if I'm already drilling on the tooth and my decay starts to go under the ridge, that's an area where I would extend the restoration to include that surface as well, rather than doing Curodont in the distal aspect. But you can see all of those areas where so in that same x-ray number 29, mesial and distal surfaces, those are excellent spots where I would absolutely use Curodont treatment. And depending on the type of software that you have and the different version of the software, this was the earlier version of the software where everything was pink. Now we have the ability to differentiate enamel lesions versus lesions involving the dentin as well. So I'm going to skip ahead past these because I want to get to a couple more slides here. So Curodont has over a 90% success rate. And I want to emphasize that just because you can't see it on the x-ray doesn't mean that the hydroxyapatite wasn't generated. There was a very good article published by Dental Advisors where they actually looked at lesions and found that hydroxyapatite crystals had formed throughout the depth of the lesion within 2 weeks. But that same tooth did not show radiographic changes yet. So just because it doesn't show radiographic changes doesn't necessarily mean that the product or the treatment didn't work. Really quickly here, for those that are not familiar with applying Curodont, it is very, very easy to do. It comes in a 2-part system with a small sponge and a dropper. You will take that sponge out of the packaging and you will use that dropper to totally immerse that sponge with the liquid. And then you want to let it sit for 2 minutes. You want it to totally soak and absorb that liquid, and that 2-minute soaking time is very, very important. While you're waiting, you're going to prepare the site. So you do that for cleaning by cleaning the surface. So this is why it is an excellent opportunity to do it when the patient is in the chair for hygiene, because that biofilm, that pellicle has already been removed. So you're going to remove the pellicle from the surface with pumice, and then you are going to etch the area. So if you are applying the treatment to an interproximal area, you are going to etch the interproximal surface and then use floss to pass that etch through the inside aspect of the surface. If you're treating a facial lesion, you're just going to etch the facial surface of the tooth, or of course the occlusal surface if that's what you're treating. You do not need to separate the teeth. You don't need to use an instrument to wedge them apart. You don't need to use an actual wedge to separate the teeth apart. So then you're going to rinse and dry the area and isolate with cotton rolls. You don't need to use a rubber dam, and you don't need to use an isolate. It's very, very easy to isolate the area. And then we're just going to take that sponge and hold it on the area for a total of 5 seconds. So you can apply it to the buccal surface for a couple seconds, and then go over to the lingual area for a couple seconds, and then you're literally done. What the company recommends in terms of post-op instructions is no spitting, no rinsing, no eating for 30 minutes. We really want to give the tooth an opportunity for the product to totally absorb. And if the patient immediately eats or drinks something, it might change the pH of their saliva and the ability for remineralization potential. So it's really important that patient doesn't just continue drinking their coffee immediately after the treatment, but you can apply fluoride right after. That is totally acceptable, but it's that easy. Don't overthink it. You can dismiss the patient. So I went over a couple of these items. You don't use waxed floss. There is no need for separators or wedges. And you want to make sure that you press the sponge on the lesion for a full 5 seconds. It doesn't have to touch the interproximal area. Of course, there's no way to get the sponge in between the tooth. You just want to hold it to that tooth, and with capillary action, meaning the tooth kind of absorbs the product into the inner aspect of the tooth. So don't re-dip the sponge into the blister. That sponge is used for one site only. So if you're treating kissing cavities, of course, it's going to treat both of those areas at the same time. But if you're treating the mesial aspect of tooth number 3 and the distal aspect of tooth number 3, you really need to open 2 different blisters. So empower your hygiene team. It takes 3 minutes to apply. It motivates education. Patients are going to want to take better care of their teeth. They're going to be more motivated to get the product to work. As soon as I started using this product in my practice, I had more and more patients who said, "Oh my gosh, what do my teeth look like this time?" They started asking for x-rays. I've had patients show up at the 6-month mark, and all of a sudden they want x-rays. They say, "Can we take an x-ray? I really want to see if it's working." And I love it because it allows me to focus on bigger treatment. I really don't want to be doing interproximal restorations. I would love to be doing all the other fun things about dentistry. Not that interproximal fillings are not fun, but to me, there are so many other fun things about my practice that I would rather be doing. Just whipping through all the other aspects of Pearl that allows you to talk with your patients about it a little bit more effectively. Good communication with our patients. So the way that I talk about it with my patient is I say, you have a small cavity that I can treat with Curodont. It's totally drill and needle free. Do you want to try it? It only takes 3 minutes. When I'm talking about price, I typically say insurance coverage varies. We can treat now and preserve your natural tooth structure without the need of the filling. That is always going to be cheaper than a filling. In my practice, I charge $120 per site. I know that across the US, dentists are charging anywhere from $100 to $150 per site. So for me, the good price point was about $120 per site. And I have great acceptance with that number. We talked a little bit about the differences between resin infiltration versus Curodont. To me, the working time kind of makes the difference. Resin infiltration is a great service for our patients, but it takes 45 minutes. It requires a lot more technique. It's a lot more technique sensitive. Its mechanism of action is different. It is occluding porosities versus the mechanism of action for Curodont is actually repairing the enamel. It is rebuilding hydroxyapatite. So it is a totally different tool. They are both important in our practices. I use them both, but they are different clinical indications. So really, I want to leave you here tonight. I'm going to open it up for questions, but I really, really hope that you leave here being motivated to try this product and start using AI in your practices to start diagnosing earlier and having easier conversations and more thoughtful conversations with your patients, because in the end, you truly have nothing to lose. Let's shift the paradigm for our patients, and let's allow patients to have better treatment outcomes. Thank you so much. Oh, really quick here. real quick here. If you have more questions about the science of Vivardis and the technology, there are great educational resources on the website. So I encourage you to check out the Vivardis website. There are a lot of third-party scientific articles that are listed on the website that you can use. So please connect with me. This is my QR code that links you to my Instagram. I love social media. I love seeing everyone's before and afters. I love when you all share me your great success stories. I would love if you guys give me a follow and show me, DM me your before and afters. I want to continue networking with you all. This is my cell phone number and my Gmail. If you have any questions, please reach out to me. Thank you so much.
All right. Thank you so much, Dr. Kelly. Let's go ahead and open it up to Q&A from the audience. So we did have a couple of questions just now about the insurance code and pricing, which you just addressed. So everyone, the code Vivardis typed in the chat, it is D2991. The next question, we have a couple of questions about how to schedule a lunch and learn with either Vivardis or Pearl.
So I encourage you to email me and then I can put you in touch with someone that can schedule a lunch and learn for you. So please either send me a DM on Instagram, or I provided my email address as well as my phone number earlier. If you need that from me, I can write it in the chat, but I encourage you to reach out to me and I will give you the name of someone you can reach out to with regards to scheduling a lunch and learn at your practice.
Another question is, do you need to remove plaque first?
Yes, it is always best to remove the pellicle from the tooth surface so that the chemical can totally absorb into the enamel. It allows for better penetration. So it is better if you use some sort of prophy paste or pumice to remove the pellicle prior to application.
Okay. Could you show again the slide for Curodont application and activation?
So this is a sequence of images, so I'm not able to show them all at one time, but essentially the product comes in two separate pouches, a application with a liquid inside of it and a separate sponge. That sponge is located within a little well that you can drop the chemical solution into and just let it sit there for 2 minutes.
Okay. Next question is, would the fluoride in the prophy paste interfere with the absorbing of the product?
No, it doesn't. So yeah, go ahead and use your prophy paste. It works really well in conjugation with fluoride. So use your normal prophy paste just like normal, and then you can feel free to apply a fluoride varnish immediately after. There's no contraindication for doing that.
Okay. A question which I know that you addressed in the presentation was, is this recommended for all ages?
All ages, yes.
What is the difference between Curodont and Icon?
So we went over that a little bit. It has a totally different mechanism of action. It has a different working time. In my practice, Icon takes about 45 minutes to apply, and it is mostly a doctor-led treatment, meaning I have them in my chair and I'm isolating, I'm applying the etch. It requires several cycles, whereas Curodont is used in usually the hygiene chair, and it takes 2 minutes to apply. So totally different time frames. Also, you have to understand that Icon is used for enamel deformities. So the area of enamel is white because light is reflecting off of the enamel and those crystals are deformed. It is essentially a developmental defect. whereas Curodont is attracted to acidity of a demineralized area. So it will not work on fluorosis. Do not try it on fluorosis or other types of white spot developmental stains. It is used for areas of demineralization. So totally different mechanism of action.
If you want to remove plaque, is it better to use a Prophy Jet or Micro Etcher 27 micron particles?
You could also do that. That is, I think, the a great way to remove the pellicle and remove plaque. Not everyone has access to that in their office. So as long as the pellicle is removed and the biofilm is removed via air jet or prophy paste, both are totally acceptable mechanisms to remove the pellicle. Thank you so much. Please reach out to me if you have any questions. I would be happy to collaborate with you if anyone has more follow-up questions.